Great. Welcome to the 8th annual MQ Mental Health Science Festival. MQ Mental Health Research is a leading global mental health charity that's invested over $25 million into research across the translational spectrum and care continuum around the world. This year's festival has been organized by an international and multidisciplinary panel of 8 people from 6 different countries, collectively bringing a huge range of expertise, including mental health activists, academics, lived experience experts, policy advisors, all led by the scientific chair of this year's Science Festival, Helen Fisher. The aim of this year's festival is around convening different disciplines and sectors to collaborate and share research and learnings to progress the field of mental health science. And this is the second day of a 5-day festival of webinars. Today, our theme: people from low and middle income countries, racialized groups, homeless people, refugees, members of the LGBTQI+ community, and people with learning disabilities are all more vulnerable to mental illnesses, either because they are at higher risk of developing a mental health condition or because they are less likely to be able to access support services and care. There's a need for increased action and further research to improve the mental health of marginalized and underserved populations, and that is what we'll be tackling today. The talks and panel discussions will be recorded and will all be made available on the MQ YouTube channel. You can find the link to that in the chat shortly. We're excited to have an international and diverse audience here today and throughout this week, including people with lived experience of mental health, researchers from various different career stages, mental health practitioners, representatives from NGOs, community organizations, funders, and many more. You'll notice that throughout the festival will be referring to people without their professional titles, and this is to make sure that in that huge spectrum of people, everyone in the space feels an equal contributor, and we hope you feel really welcome to contribute today. Please do remember when commenting that we have a diverse audience watching today, including people with lived experience of mental health. So please, let's be really kind and respectful in all of the words that we use. Throughout this week, we'll be discussing topics that some people might find challenging or upsetting. If you do feel at any point triggered by anything that's been discussed, then please do feel free to mute and step back and check out MQ's Get Help page on our website, where you can find a list of resources and helplines. If you're on Twitter or other social media platforms, we're really keen to hear your thoughts on the talks and discussions, and you can use the hashtag MQ Science Festival. And the MQ Mental Health Twitter today is being taken over by our lead for mental health inequalities, Mariana Bolivar, who'll be giving her take on the discussion that's going on. So do please engage with that. During the talks and panel discussions, we are in a Zoom webinar format, so you won't be able to use your sound or camera. So please make sure you use the chat function. And if you want to put any questions to the panel, there's the Q&A function at the bottom that you can drop your questions into. At the end of today's webinar, we'll be holding a breakout space in a Zoom room so people can share and network and give their reflections, and we'll talk more about that at the end of the presentations. For now, I'd like to encourage everyone to introduce yourself in the chat by answering 3 questions. 1, drop your name and any links to your social media handles in there. 2, which part of the world are you joining from today? We've got over 400 delegates across the week from around the world. We'd love to hear where you're from. And the key question: what do you think the biggest challenge is in mental health research in challenging inequality? What do you think the biggest challenge is in mental health research and challenging inequality? So name, social media handle, where you're from, and your first thoughts on that. Do type that into the chat as we get started. And as I say, questions in the Q&A box throughout, and they'll be curated for the chairs of the panels. It's now my great privilege to hand over to the chair of our festival, Helen Fisher. Helen is a professor of developmental psychopathology at the Institute of Psychiatry, Psychology and Neuroscience, King's College London, here in the UK. Helen's research focuses on early risk factors that predict the development and persistence of psychotic experiences in childhood. We're delighted that Helen has been an MQ Fellow. She's also received several national and international awards, including a recent Emerging Leaders Prize in Adolescent Mental Health from the UK Medical Research Foundation. We are excited and delighted to have Helen as the chair of MQ's Mental Health Science Festival this year. Helen, over to you.
Lovely. Thank you so much, Lee. Real pleasure to be here and to welcome everyone to this amazing second day of the MQ Mental Health Science Festival. As Lee has already said, today's theme is the mental health of underserved populations and marginalised communities. And we'll be hearing from a really wide range of speakers and panelists. So really looking forward to hearing that and the discussions that emanate from it. So our first session will be chaired by Anna Boja. Anne is a consultant forensic psychiatrist at Tees, Esk and Wear Valley's NHS Foundation Trust and is commissioning clinical director for adult secure mental health services across the northeast of England and North Cumbria. She's a founding member of a forensic mental health collaboration between the UK, Latin America and the Caribbean. And with this collaboration is aiming to improve the mental health of individuals with a risk of or a history of offending. You can find the full biographies of our chairs, speakers and panelists on the festival page online. So please do check that out during the week. So without further ado, I'm going to hand over to Anne now. Welcome, Anne, to chair our first session. Thanks so much for joining us.
Many thanks, Lee, Helen, Parisa, and all the festival organisers, and good afternoon to everyone. It's an honour to chair the first session of day 2 of this excellent science festival. Aspirationally, mental health care services across the globe would effectively serve all populations, but sadly we know that in every country there are populations who remain underserved. I'm therefore delighted to be joined by our 4 esteemed guests with an interest in this area. We will begin with 3 presentations, followed by a panel discussion with time for questions and answers. So please, as you've been invited, do write your questions in the Q&A box at the bottom of the screen and not in the chat, please. So it's my pleasure to welcome our first speaker, Raj Mariwala. Raj is the director of Mariwala Health Initiative, an organisation in Mumbai, India. The title of her presentation is Decentering Hegemonic Narratives, Mental Health from the Margins. So Raj, I invite you to unmute, switch on your camera and start sharing your presentation, please. Thank you.
Okay, thank you so much for having me here. I'm not going to present the slideshow in just to save time, but it is around. So if anyone wants it, just get in touch with me and I'll mail it. So, I think the next part of this is going to be a discussion, and a bit of it is going to be on policies. But before we even discuss policies, marginalized communities, as the panel coordinator said, are invisibilized in the larger discourse around mental health, especially in LMIC contexts. And much of this is to do with how the discourse is centered. It's centered around the biomedical, it's centered around estimates of disease, it's centered around lack of psychiatrists, the treatment gap, which let's face it, is a problem everywhere and not just in LMICs. So it's insufficient for us to discuss issues of marginalized communities. But not only is it insufficient, it also hinders how we understand issues that marginalized communities may experience, as well as issues they may face in accessing mental health care. And it doesn't help to explore inequalities in mental health, what causes them and what perpetuates them. So I'm going to say that let's think of it like this. Structural oppression and systemic barriers decisively affect an individual's well-being, and then further affect access to mental health care and support. Now, this approach allows us to situate mental health within people's lives, experiences, and contexts, with the understanding that marginalized individuals, of course, are disproportionately impacted by mental health concerns due to greater exposure to stressful events, but also a lack of social support. Now, what does this mean in tangible terms? In the South Asian context, ability, caste, class, ethnicity, gender, sexuality, and religion all play a pivotal role in determining daily stressors, exposures, susceptibility to mental ill health. And these same mechanisms of what I call structural oppression also affect access, provision, and suitability of mental health services. So essentially the recourse one can access, both in terms of mental health support wider social supports, and of course, in the quality of care and support received. Now, unfortunately, this same structures of oppression also govern public policy and socio-cultural norms, be it health, social, or economic. And all of these interlock, exacerbate, and perpetuate the situation for those who are marginalized. So one example, now using the lens of structural oppression, tells us that women who face gender-based violence also face homelessness. Now, those who face gender-based violence experience depression, anxiety, stigma, shame. We know this. But if we use the structural oppressions lens, due to caste, gender, and ability, certain women aren't included in our programs. Trans women, Dalit women, Adivasi women, sex workers, women with disability, they're not included. Now, what happens there? Double oppression, trans persons are more vulnerable then to even more to homelessness, living in poverty, lack of employment, job security, social isolation due to entrenched prejudice, which then intensifies mental health concerns such as suicidal ideation. Now, like I said, policy interlocks to create this. Social safety nets, such as livelihood services or services for housing, require formal identification, which is in almost all scenarios inaccessible for trans persons. Now, this is also true for Dalit persons who are homeless. And in fact, 5 out of 6 families, multidimensional poor families in India, are from marginalized caste backgrounds. So what I'm trying to say is that a lot of this is embedded in our systems and in our policies themselves by dint of invisibilization and structural exclusion. And while policy changes may have significant effects, there also have to be changes within healthcare structures. Now, there have been progressive judgments on gender, sexuality, and caste, yet mental health professionals in India practice violent conversion therapies. Mental health and physical health professionals in India, again, have embedded within their healthcare structures prejudice and structural oppression, where they don't want to treat persons from Dalit communities. They may not want to touch persons from Dalit communities and not provide them any sort of examination either. So overall, mental health curricula also needs to be reformulated to understand structural oppression and recognizing that these inequities shape how we do mental health in and of itself. So in effect, what I'm saying is that there's a massive interlocking of different ways of structural oppression, which is, I am terming it social causation, which leads to increased exposure to violence, increased food insecurity, reduced access to social safety nets. All of this increases the likelihood of people developing mental health issues. So it's not enough to provide mental health services or look at it only as a service-led thing, but linkages to services that support livelihoods, shelter, and social inclusion, and looking at the whole thing together as a care gap. Because if we are to, okay,
I'm ready.
Oops, one more sentence. We must design for the margins, because if we design for the margins, everyone is covered. But if we build for the center, we may never reach the margins.
Thank you very much, Raj, for proposing how we can redress the margins to take action and address this session topic. I am delighted to welcome our second speaker, Shekhar Saxena. Shekhar is a professor of the practice of global mental health at Harvard University in the USA. And the title of his presentation is 5 Actions That All Countries Must Take. So thank you for unmuting, and Shekhar, I'll hand over to you to present. Thank you.
Thank you very much, Anne, and also to MQ for inviting me to join this science festival. My 5-minute intervention goes straight from where Raj left. What are the policy actions that countries could take? And I'm going to describe 5. And I've underlined the word all. That means large and small, rich and poor, all countries need to take these actions. The first action is to decrease disparities, because we do know that disparities are bad for mental health. And also we know that decreasing disparities improve mental health and for all, not only those people who are marginalized and underserved, but for the entire population. So my first recommendation is countries must strive hard to decrease disparities. Now, disparities should anyway be decreased, even if it was not for mental health, but mental health certainly is one of the reasons why countries need to decrease disparities by whatever social and economic programs and other strategies that they might have. My second recommendation is to support child development because we know that adversities during childhood have a very strong negative impact on mental health, and that goes on throughout life. And we also know that providing psychosocial support during childhood improves development of the child and also mental health of the person in future. And we do know that supporting child development for marginalized and underserved population has a very high return on investment. If we start talking about gained health as well as gained dollars or pounds, they all have a very high return on investment of this investment. So countries need to invest and support child development. My third recommendation is to increase access to care and treatment. And we already heard Raj talking about how the marginalized and underserved population have decreased access to all kinds of services, but also for mental health care and treatment. And we do know that all the member states of United Nations, which practically includes all the countries in the world, have signed on universal health coverage to be one of their basic strategies for delivering health, and health must include mental health. As we have talked for a long time, there is no health without mental health. My fourth recommendation is to monitor mental health and well-being, because if we do not measure, we cannot improve mental health and well-being for anybody, including and especially for people who are marginalized and underserved. And governments are accountable for mental health and well-being for all, including and especially populations which are marginalized and underserved. And Raj very beautifully described the kind of people who are marginalized and underserved in many countries, including in India, which she knows very well. And so governments have this primary responsibility to improve access to care, but also to monitor mental health and well-being so that they can take the relevant actions that are necessary. And finally, my fifth recommendation, facilitate, fund, and use research. All three are important because we do know that everything about mental health we do not know everything about mental health of marginalized and underserved population. We do know a lot, but we don't know everything. And so we need to do research to find out more and to accumulate knowledge. The causes, needs, and interventions for mental health vary widely across populations. So what is true for other segments of population may not be true for marginalized and underserved population. Better knowledge will mean more effective promotion, protection, prevention, and care for this segment of people. So these are my 5 recommendations for all of you who are listening to this. Go to your governments, approach them, and ask them to implement 1, 2, or hopefully all 5 recommendations. Those of you who come from UK, go to your newly minted Prime Minister and ask for this. Those of you who are from other parts of the world, go to your prime ministers and health ministers, whether old or new, and ask for these to be implemented. Thank you very much, and back to you, Anne.
Thank you very much, Shepherd. Thank you for making a clear call for universal action to improve the mental health of these populations. I now offer a cordial welcome to our third speaker, Crick Lund. Crick is a Professor of Global Mental Health and Development at King's College London in the United Kingdom. The title of his presentation is Intervening to Address Social Determinants of Mental Health, Challenges and Opportunities. So, Crick, if you'd like to unmute, switch on your camera and start sharing, you're ready to hear what you have to share with us today. After we've heard from Crick, we will be moving on to our panel discussion, and then there'll be an opportunity to include questions from the chat. So please do continue writing your questions in the chat for our speakers, anything you've heard them say during the presentations or during the panel discussion. I'm more than happy to have your contributions. Okay, so we're just waiting for Crick to rejoin us. Once he has rejoined us, I would have been asking our fourth person to join us. It seems Crick has been having some technical problems. We know he's going to be speaking about the challenges and opportunities. So I think perhaps we will go into the discussion, and maybe I will ask if our fourth person will perhaps just share some thoughts. And if at the end of those thoughts, Crick has joined, we'll hear his presentation and then have the panel discussion. If unfortunately he's not able to join us, we will continue with the panel discussion. So I'm very pleased to welcome our fourth guest of the panel, Tanatswa Chikaura. Now, Tanatswa is the founder and director of the Indenewe Foundation in Zimbabwe, and she's bringing the activist and lived experience perspective to the panel discussion. So before we have any questions, and indeed Crick may well pop back into the webinar and join us, Tanatswa, thank you for coming and joining us and bringing this really important perspective. I wonder if there are any thoughts you want to share in a few minutes about this topic.
Thank you. Sorry, my voice may crack up a bit. I'm recovering from COVID. So it was a terrible week last week.
Oh,
I really liked Raj's presentation. In fact, I liked both presentations, and how she touched on how the discourse is centered and how that is insufficient for us to even have conversations about mental health of marginalized groups. And she touched on something that was very powerful for me when she mentioned how there's structural oppression. And in these situations, you have people that are fighting to get food on the table. You have people that are focusing on their livelihood. And with them focusing on their livelihood, how then do they focus on mental health issues? That's then the question. The question is then from them is, talking about mental health support is more of a luxury. So what I would love to know from the discussion when we continue is, how do we strike a balance? How do we then sensitize people about mental health issues, people that are already focused on their livelihood, people that are already focused on them just surviving, and trying to then tell them that your mental health matters, your well-being matters as well.
Right, thank you very much, Tanatswa. I'm certain we're going to have a very stimulating discussion. So I hope that our other panelists have been taking notes on your comments. Thank you very much for sharing that. I'm really pleased, absolutely delighted that Crick has managed to join us for this. So he's, if you'd like to unmute Crick and you could start sharing your presentation, or if you're speaking without a presentation, then I'll hand over to you. The floor is yours. Thank you very much. If you could just enlarge it a little so we can see just the presentation.
Sure. Can you see the presentation now?
I can see the presentation. I can see your other slides at the bottom.
Okay, let me just see. Is that better now?
That's perfect. Thank you very much.
Okay, great. Thank you very much, Anne. And my apologies for the technical glitches. It's really good to be with you and to be with everybody online. My name is Crick Lund, and greetings from Cape Town in South Africa, where I'm based. It's really great to be part of this panel and to be addressing this really important topic. And what I'm hoping to share with you is some of the work that we've been doing to try and understand more about the social determinants of mental health. And I want to share with you some of the challenges, but I also think some of the opportunities for intervening to address these social determinants. So let me dive straight into it. I know I only have 5 minutes or so. This is a framework that we developed as part of the Lancet Commission on Global Mental Health and Sustainable Development. back in 2018, and Shekhar, who's on this panel, was very centrally involved in all of this work. And essentially what we did was we went through a process of reviewing the existing systematic reviews. I think we covered around 289 reviews in this review, really mapping out the different social determinants of mental health and trying to organize them in a way that made sense. And so we developed this framework which covers 5 main domains. There's the demographic domain, the economic domain, the neighborhood domain, the characteristics of the area or the neighborhood in which you live, the environmental events domain, including, for example, natural disasters, industrial disasters, war and conflict, and so on, and then the social and cultural domain. And within each of these domains, social determinants exert their influence across the life course through a combination of what we might call distal factors and more proximal factors. So, for example, economic recessions exert their influence on mental health through their impact on reducing income, increasing debt, eroding assets, bringing about more financial strain, and so on. And very importantly, these interact with genetic risk factors across the life course and their key developmental life stages, which are really important and mark particular periods of vulnerability to mental health problems. Now, what all of this raises for us is, could we be thinking more about how to intervene to address these social determinants? And in late 2019, I was part of a meeting organized by the Academy of Medical Sciences and the Inter-Academy Partnership on the social determinants of global mental health. And we met, there were representatives from about 36 different countries. And we met to really try and brainstorm the potential interventions to address these social determinants. And we used this framework, identifying interventions for each of the main domains, the demographic, economic, neighborhood, environmental events, and the social and cultural domain. And I don't have time today to go into these in detail, but if you'd like to read more, Kelly Rose Clark led a very nice commentary paper in the Lancet Psychiatry in 2020, which provides a bit more detail on some of these. But these are just some examples of the kinds of interventions that were identified. So in the demographic domain, interventions to address gender-based violence. In the economic domain, interventions for social protection, for example, cash transfer programs, which are now quite widespread in many countries around the world. In the neighborhood domain, urban renewal programs. In the environmental events domain, disaster responsiveness interventions. And in the social and cultural domain, interventions to promote social capital or trust, and to promote and strengthen access to quality education. So all of these are potential and promising interventions. However, when we consider these interventions and we start to try and design studies to evaluate their effectiveness, we are immediately faced with a number of challenges. The first is often the interventions are quite distal to the mental health outcome we're hoping to achieve. Secondly, the mechanisms by which these interventions might lead to a mental health improvement are quite poorly understood. Thirdly, in order to design these studies, we really need interdisciplinary approaches. We need to make the field and develop much more opportunity for collaboration between different disciplines. Fourth, there are major structural challenges with many of these interventions. And fifth, there are limited available data sets in low and middle income countries. There have been relatively few randomized controlled trials, and often the mental health outcome measures lack cultural validity. And then there are important ethical challenges around how you would design, for example, a randomized controlled trial in these quite challenging adverse social and economic settings. And finally, there are challenges for research funders. They need to support interdisciplinary research when mental health research funders often work within particular disciplines, and they need to convene interdisciplinary review panels. So I'm just going to close off where I'm just about out of time. So let me just briefly mention some potential approaches. I think it's very important that we try to build theoretical models to understand the mechanisms by which social and economic factors influence mental health. And then we need to test these specific mechanisms in these hypothesized causal pathways to test whether intervening on a particular mechanism might lead to a particular change. And finally, we need to pool data across multiple sites because context really, really does matter with these kinds of interventions. So just to conclude, we're now embarking on a very exciting new study funded by the Wellcome Trust called ALIVE, which stands for Improving Adolescent Mental Health by Reducing the Impact of Poverty. And in this intervention, we are designing, in the study, we are designing an intervention which includes some anti-poverty strategies, for example, financial literacy and cash transfers, together with interventions to strengthen self-regulation, which we hypothesize is a key mechanism linking multidimensional poverty to the incidence of depression and anxiety. And we're working in Colombia, South Africa, and Nepal. I think my time is up, so I just leave it at that. Thank you very much, Anne. Thank you for listening, and I'm looking forward to hearing your comments and questions. Thank you.
Thank you very much, Crick, for sharing about the challenges and opportunities for taking action to address this very important topic. So I'll now ask all of our panel speakers, first again, thank you them for their excellent contributions, their presentations and thoughts, to unmute and to put their cameras on so we can start the panel discussion. Now, just before Crick spoke, Tanatra very kindly shared some of her thoughts and reflections on the first two speakers. So I'd like to invite Raj or Shekhar to respond to Tanatra's initial thoughts and questions. Either one of you, feel free to start.
Raj, do you want to go ahead?
Okay, sure. I think that's a great question. Thank you, or your comments. And I'm going to say that's part of why I say that we should decenter hegemonic or dominant narratives around mental health. For far too long, our definitions of mental health have been too narrow. And yes, there are many people who are structurally oppressed, who may be living in poverty, who are worried about where the next meal is going to come from. And I'm going to say that these are interconnected. So for example, food insecurity, it's a risk factor for both mental and physical health. Now, even if we look at undernutrition, there's a lot of distress that accompanies that. There is anxiety, shame, powerlessness, and guilt. And of course, this type of food deprivation is then linked to higher probability of non-communicable diseases as well, such as diabetes or cardiovascular diseases. Now, what this does is that it actually increases healthcare costs for these communities and these folks. And so I want to say that there are some very deep interlinkages between poverty, homelessness, and mental illness. Now, research in India has shown that a homeless individual is already at an increased risk of developing mental illness. And there's also an increased risk of becoming homeless if you live with a mental illness. So in fact, the likelihood of living with a mental illness is 3 times greater for those who may be facing homelessness or are homeless. So, and of course, there are psychological dimensions to this as well: high levels of stress, uncertainty, anxiety, and possibility of greater exposure to violence, both from individuals, communities, but also from the state. Unemployment, lack of access to education, and of course, adverse childhood experiences. So I'll stop there and, Shekhar, if you could.
Sure. Thank you very much, Raj, and thank you, Tanatra, for asking difficult but very relevant questions. Besides what Raj mentioned about the interlinkages and the double, triple, and multiple jeopardies that marginalized people suffer from in health as well as other areas, I would suggest that it is the involvement of the people who are marginalized and underserved, which will actually shed much more light in what we're trying to do. And I pointed out as one of my recommendations, more research, which can be done only with their involvement. And Crick mentioned some of the studies that have been done and some of the other studies which are being planned. Quantitative information can take us only that far. It's the qualitative information, it's the engagement with people who are having that issue the underprivilegement, as well as the mental health issues. That will shed a lot of light on what we are trying to do. All strategies, all policies for the entire area need to be developed based on scientific evidence, but based on a full and fair consultation with the people that the strategies are trying to serve. So that is the only addition that I would like to make.
Thanks, Shekhar. Before I ask Crick if you'd like to perhaps comment on that and take it further regarding research and how we should be doing this, I think Tanatsa has a comment to make.
Yeah, I just want to say that I like that you talked about research, and also Crick mentioned cultural validity, which is something I struggled with for a very long time, because initially when I started advocating for mental health, I never saw anything that was in the Zimbabwean context. And I found it very problematic because the way people view mental illness, or the way certain concepts are viewed, it may be different from the way other people in other regions also view it. And the question is, does it mean that the way that perhaps certain groups of people are viewing mental health is wrong as compared to others? Again, how do we then find a balance? Where do we strike the balance? And it's even with language, what depression is in English may not exactly be the same in Shona, which is my local language. I don't even know what depression is in Shona, actually, because the words are not there. And when you try to look for the words, there's so much stigma associated with those words. And I think it all comes back to the way research is being conducted. We just uproot it with these perceptions and ideologies from a certain area and just take it to another area, expecting people to just copy and paste. And I don't really think that works. So that's what I wanted to add.
Thanks, Natswa. Crick, over to you.
Yeah, thanks, Anne, and thanks to Natswa. I mean, I think these are really, really important points. The whole notion of including people with lived experience and from marginalized groups in research is so critical in all of this. And I think it's important not only because it enables us to understand more about their experience and how the research could address their particular needs, but also the terms that they might use really help us to get over the kind of challenges that you were describing, Tanatwa. So just to mention on the ALIVE study, which I was just describing now, in each research site, we have an adolescent advisory group, which we've established. And we meet with this adolescent advisory group every 2 months. And we present an update on how we're going with our research. And we involve them in a whole range of questions, from the study design to the intervention design, to the kinds of terms we should use when speaking to young people about their mental health concerns in the local communities. And we have a formal sort of information flow process where the questions that we raise with the adolescent group, the advisory group, we will then feed back into the research process. And then the next time we meet with them, we will report back to them on how we've been going, how we've taken on board their suggestions. And we make sure that we document that in a rigorous process. And this could be really extended to a whole range of different populations, working with older people, working with homeless people. This is really such an important part of how we should be going about our research in a whole range of different areas. Thanks.
Thanks, Crick. And perhaps just like to take the opportunity to add there that currently, working in cross-culturally, we've taken the view that we would use not a common language, but a shared language. So we take it in terms of whether we share and discuss in Spanish or in English, which means everyone starts with an equal footing as well. So language, as Tanatsa mentioned, is important, and again, echoing the things that Crick said. Just wanting to think a bit more about where we're going with, improving things for these populations. So as we're planning and taking actions and engaging with policymakers, lived experience groups and different stakeholders, which new marginalised or underserved populations do you think are likely to emerge over the next 10 years?
I can take that, Anne, as an initial suggestion. I think the climate change is going to give rise to a lot more people who will be underserved, have excessive risk of having mental health problems, and will become increasingly marginalized. And that is going to be true in low and middle income countries, but also true for many rich countries where marginalized people are also plenty. So I think that is the group that we need to look out for, watch, and as I said, monitor their mental health and see whether we can develop newer models to protect them as well as to provide care when necessary. Over.
Thank you. Do any other panelists have any responses or thoughts on that? Quick, thanks.
Yeah, just to add to that, I mean, I really agree with Shekhar. I think for me, the other big area of concern is the sort of global trend of widening income inequalities. And so we're seeing these huge disparities between rich and poor, which cuts across a whole range of areas from health access to education, to livelihoods, to community cohesion. And so this sort of underpinning driving force of inequality, I think, is a key one to watch in the generations. So we don't see any sign that that is improving. In fact, the trend post-COVID is that inequalities are widening. And so I think the more that we can do as mental health advocates to speak out about inequalities and how these can be addressed in policies, I think the better. Thanks,
Craig. And Raj?
Just quickly, I want to say that I actually completely agree with Shekhar, when he says climate change, but also because I think the climate change discourse and the mental health discourse don't talk to each other. And as Tanatswa said, the Eurocentric is a default in our dominant mental health narratives as well. And while LMICs will face the brunt of climate change, again, our solutions for mental health and climate change are all coming from a Eurocentric, expert-led, biomedical-ish kind of perspective that is dominant, and it must be decentered.
Thank you. And Tanatswa?
I also want to add that I think that childhood and youth mental health is an area that really needs a lot of research and various interventions. I really like that Shekhar spoke about having child development. I once had a conversation with some doctors, I think it was last year, and I asked them that when a woman is pregnant in Zimbabwe, and she comes to the clinic or hospital, you're gonna tell her like the needs of the baby, like milk, don't do this, have this much iron, and all the other stuff. But you never talk about mental health. You never talk about pre and postnatal depression. You never talk about how that bond, the child-parent relationship, and how the child's mental health is important. And I do believe that that should be incorporated, at a very young age when a baby is actually still in the stomach. That's what I told them. So I do believe we do need more research in those areas. Right now in Zimbabwe, the rate of substance abuse is just unbelievable. There's an increase in substance abuse, and it's really terrible. And something needs to be done. We do know the risk factors. We do know what is pushing. So should we just address the social determinants, as Craig mentioned? But in doing all of that, what about well-being? What about mental health? And I believe that it's important for us to have tailor-made treatment plans for people. As much as we continue talking about ease of access to mental health services and having the mental health services available, it's just not enough. We need to know what is happening. What are the underlying mechanisms of mental illness? What is going on? And how can we have tailor-made strategies, which then comes the interdisciplinary research that Craig mentioned. So I do believe that the future is bright, but there's definitely a lot of work to do.
Thanks, Tanatswa. It's been a really good panel discussion. I think it's now time to take one or two questions from the Q&A in the chat. So thank you so much for putting these forward. Please keep them coming. So we've got a question for all speakers, so maybe one or two would like to pick up on this. What do you think are the challenges and opportunities of digital tech to improve access for marginalised and underserved communities and populations? Shekhar, would you like to take this?
Sure. And actually, I wanted to answer that question. I think digital tech can certainly help, but we need to be extremely careful that by using those technologies, we are not marginalizing the people even more and increasing the inequities that they are already suffering from. However, I just want to point out that digital tech does not mean only delivering care by digital means. In fact, digital tech can assist a lot in improving the system overall by training the people who will eventually provide care, and by maintaining records and supervision and support that can be extremely useful to finally deliver care that is appropriate, is accessible, is affordable, and is relevant to the population that we're trying to serve. So if we take the digital tech in its wider sense, I think it can be extremely useful, but we need to be very careful that we are not increasing the inequities in this system. Thanks.
Right, thank you. So that's would you like to answer this one briefly? Then we will have to move on to another question.
I also want to add to what Sheka said. In some communities, or in some African communities, the using a community-based approach is something that's very powerful when trying to provide mental health services or provide mental health education. And within incorporating digital tech in the mental health space, we should be careful also not to overtake that, but always maintaining a human-centered approach. That's what I wanted to add.
Thank you very much. And our last question, and we'll perhaps have time for perhaps one or two brief responses, is what do we do when the margins keep moving for marginalised and underserved communities? For example, the frameworks we continually end updated, the frameworks we use continually end updated as the landscape changes. So this is about how do we move quick enough with these changes, given how long our outcomes and goals take to meet. So basically, how do we keep up with the changing environment? Raj or Krik, would you like to respond to this?
Yeah, I can respond, Anne. Thanks. Well, I think it's up to us as researchers to be nimble and to be responsive and to keep moving with the field, you know. And as we've seen in global mental health research, I mean, the field is fairly young and it's evolved so rapidly in the last 20 years or so, since the landmark World Health Report 2001. The field has really grown enormously. We know a lot more now about what interventions work. We know a lot more about task sharing approaches using non-specialist community health workers and primary healthcare workers to deliver mental health interventions. We also know more about interventions to address the social determinants of mental health. But at the same time, it's really important that our language and our terminology keeps pace as well. And I think a couple of the speakers, including Raj and Tanitwa, have spoken about this, you know, the importance of consulting with and engaging with people with lived experience and including them in the research process, because I think this helps us to stay current and to keep up with rapidly changing fields.
Absolutely. And Krik, thank you. I think you've summed up our session very nicely. All the wonderful contributions from our four speakers, Sheka, Tanatwa, Raj and Krik. I'd like to thank you very much for your contributions. And everyone who's shared their thoughts and their comments in the chat and sharing good practice and posing really difficult questions for us to grapple with as we move forward. And also for those who ask questions. We've not had an opportunity to answer all the questions, but please go away, you know, in the discussion groups later on, in your own networks and community. Do keep working and trying to find answers for these. So having thanked everyone, I hope we're all leaving better informed. And I'd like to hand over now to Helen as the rest of us switch our cameras off and mute our microphones. Thank you.
Perfect. Thank you ever so much, Anne, and all the panelists for that fantastic and really thought-provoking session. You've raised so many important issues and challenges in this space, and really taking away, thinking about using an intersectional lens, really thinking about how important it is, as we were in yesterday's session, about collaborating with others, particularly those from marginalised groups and those with lived experience and mental health difficulties, and also how we really must think about how we tackle social and economic determinants of mental health in this space. So thank you so much. And we'll now move on to our second session of today's MQ Mental Health Science Festival. And we're continuing with the topic of mental health of underserved populations and marginalised communities. So our next session will be chaired by Usman Mandani. And Usman is a research lead in the mental health translation team at the Wellcome Trust and leads an amazing portfolio of psychosocial and non-pharmacological interventions. Before joining the Wellcome Trust, he led cutting-edge randomized controlled trials of psychosocial interventions and policy impact in low-resource settings. So without further ado, I'll hand over to Usman to welcome us to the next session. Thank you so much.
Thanks, Helen. Thank you so much for the opportunity, and to the speakers from the previous session. Actually, they have really set the stage right for us to dive deep into the talks that our speakers are going to be talking today. So first speaker is Professor Meena Fazal, who is the Professor of Adolescent Psychiatry at the University of Oxford. And she has done amazing work on actually different approaches on increasing access to mental health interventions for children and adolescents, with a particular interest in school-based interventions. And today she is going to be talking about reflections on belonging in the post-migration environment. So over to Professor Meena Fazal.
Thank you very much. Very nice to see you all here, and nice to see you again too, Usman. So thank you for inviting me. So as Usman said, I'm a child and adolescent psychiatrist, and I've been working in the area of refugee mental health, and particular refugee children in contexts like the UK, so what we call the post-migration environment. And trying to understand what are the right configuration of services, how best to help. And actually, the more and more I've been working in this area, the more kind of struck I am about issues of belonging, and how actually mental well-being is so inextricably linked for many of these individuals with the feeling of belonging. And actually, that's sort of what adolescence is all about. So you bring kind of moving forced migration in at a time of adolescence, that actually feelings of belonging come to the core. And so my real interest in this, so I have a few slides to share with you about some reflections on what I've called belonging for this. So when we think about kind of the post-migration environment, this is the context that, you know, is very, very disturbing. If you think about what many individuals might have gone through arriving into a new context, you know, so why is this so important? You know, so many young people are going to be experiencing forced migration. There's lots of different statistics, but it's around 1 in 8 children born today will experience some form of forced migration. And I feel that it speaks to something that's at the intersection of so many crucial areas of the determination of health: biological and individual predispositions, familial environments, and then the whole environmental and social context. And although I'm a medical doctor and a psychiatrist, I also did my first degree in social anthropology. And this is where I think it really comes to the fore. It's all absolutely essential. And then we've got so many challenges with the evidence base, with contextual sensitivity, with non-holistic approaches all the time. And so thinking for refugee populations, you've got these influences that come pre, peri, and post-migration at all these different contexts: the individual, the family, the community, and the society. And we know that exposure to difficult events are strong risk factors for later mental health problems. But I'm really interested in this, what I call this really cloudy post-migration environment, that kind of is this, I look upon this as sort of a storm cloud. Like when individuals finally arrive in a post-migration environment, what our responsibilities are not to add to instability and distress and compromise well-being, and just to do everything we can to make that cloudy storm cloud into something a little bit more sunny. So thinking a little bit about belonging, we've got to take this kind of developmental, multi-level and interdisciplinary view of belonging, but it's coming to a sense of relatedness and this close, reciprocal, supportive bonds of belonging to people, to places and communities. I also run something called the Oxford Student Survey, which is of all children in schools in certain parts of the UK, and 30,000 young people filled this out in 2021. And actually what's coming across so much of these indicators of loneliness, of belonging, how important they seem to be in their associations with mental health problems. And so when we're thinking about refugees at schools, I often talk a lot with schools about the fact that actually a lot of the most powerful mental health interventions are those that are not at all accessible to me as a psychiatrist working in whatever context I'm working at. Because actually, from the interviews with young people that I've had, and I was really struck. At one point, I did a study where I interviewed 60 secondary school-aged refugees and asylum seekers who'd living in Wales, Scotland, and England, and asking them, about their experiences and what might have helped. And actually, for all of them, this very, very strong message came out that the thing that brought about the change in their mental health, and that being either that they felt they could make friends, or they felt that they could seek support that was offered to them, even though they hadn't been able to accept it before. A lot of this hinged on a crucial factor of a local kid making them feel like they were a friend. It's a really, really simple, desperate requirement for authentic relationships. That, having an allocated friendship wasn't what was needed. Actually being in an environment where, through structured or unstructured environments at school, often through sport or through music or through giving a talk at school on something unrelated that made other children laugh, that enabled them to break the barrier where they felt accepted. And that seemed to be the crucial factor enabling them to feel better and their well-being. So that's why I feel like we need to really think about belonging, and this focus of, the child being, part of this whole environment. And actually, if we want to help the child, maybe we need to be thinking about issues in school and peers and taking the focus away. And actually, in all the studies we've done, and I was involved in kind of a big review with Therese Betancourt that was published in Lancet Psychiatry around kind of how we can prevent mental illness in refugee children. And I'm not going to talk to the details of this busy slide because it's all in the paper, but actually what's really interesting is that actually we couldn't find any studies looking at what would enhance belonging, what interventions could be done for the post-migration community, for the whole school, rather than for that individual refugee child. But actually, what can we do to make a community more able to be accepting of these young children and families, and that actually how important that might be for their well-being. So as I come to an end, I do think, as I talk about this moment of change for young people, that they felt they were able to accept help when they felt accepted. There's two sides of the same coin in schools. It can be the place where they're most likely to build those relationships, but it can also be the place where they feel most acutely that they don't belong. And on that note, I'll stop. I look forward to discussing it more, but I have had many people help me, so some of those names are there as well. So thank you very much.
Thank you so much, Meena, for the very enlightening discussion around the post-migration environment and the context that's so important, and the role of schools potentially that they can play in promoting youth mental health. And we're going to have some interesting discussion in the post-presentation session. So thank you so much for your time and the discussion presentation. Our next speaker is Professor Helen Minnis, who is a professor of child and adolescent psychiatry at University of Glasgow. And she's going to be talking about learning from underserved parents, co-production of an intervention for children with a social worker. So over to you, Professor Helen Minnis. Thank you.
Thank you so much. Can you hear me okay?
Loud and clear. Thank you.
Good, good. So yes, I'm going to talk briefly about an intervention study called Partnership for Change. So the focus now is on parents and their children. But again, I think belonging is the key to this. It follows on so nicely from what Meena has just said. Back in 2009, we started investigating an intervention for infants who've come into foster care called the New Orleans Intervention Model, developed at Tulane University by Charlie Zena and Julie LaRue. And it had been offered to any family with a baby or a preschool child coming into foster care in New Orleans and in other parts of Louisiana. And we've been investigating it in a randomized controlled trial, NIHR funded. Can't give you the answer yet because we haven't finished, but we've recruited with 480 children, and we're in the process of finishing our 2.5-year follow-up. But throughout that study, everyone kept saying to us, why don't you go upstream and try and catch problems earlier before the child is actually at risk? And we kept saying that will be another study. So we've now been funded to see if we can co-create a new team Still trying to decide on the name, aimed at families where the child has a social worker. And the study is called Partnership for Change. It's funded by What Works in Children's Social Care. And we're just in the co-production phase at the moment. So far we've done 14 qualitative interviews with a wide range of stakeholders, social workers, health visitors, clinicians, etc. We've done 5 focus groups, and we've done intense thematic analysis of meetings, particularly with our parent collaborators. So in terms of our findings of this phase 1 co-production, where we're producing this with parents who themselves have had a child in the social work system, we've really, I would say the core of our findings is that we need to develop and support a partnership of equals. And if any of you saw Sharon Graham's poster presentation yesterday, that's what we called it. Because we've discovered from that qualitative work that we need agendas to be shared between clinicians or social workers and parents. We need to be more aware of neurodevelopmental conditions in young children and in their parents. We need to be much more aware of poverty. You know, we can't be accusing a parent of neglecting their child because there's no food in the fridge on a Friday if they've actually run out of money. We all now believe that we need to be employing experts by experience in the new team. And these things now are more about values, but we need to really work on respect so as to reduce the sense of shame that many parents have if their child has a social worker. And we need to practice that respect in practical ways. And I put that in purple because I'm going to go into that in quite a bit more detail, because the ways that we need to do that are very clear, but they take a lot of work. We need to pay people in advance if they're collaborating on the project, particularly if they're living in poverty. We need to provide lunches. Sounds silly, but it's so important. Consider working around school pickups. One of the things we need to do with parents who are struggling themselves but are collaborating on a project like this is to have individual check-ins and make sure that they're always managing everything. And the big outstanding questions from this co-production period is, how do we balance the voices? So we are co-producing these new teams from existing infant mental health teams, and we've got something like 35 professionals involved in those existing teams, and we've got 10 parent collaborators, 5 in Glasgow, 5 in Bromley. How do we balance that so that everyone gets an equal voice? And how do we value experience that is not endorsed by school or university qualifications, but is just as important? Sharon Graham, who's our co-investigator and lead for the parent collaborators, and she herself is an expert by experience, has been key to this process. If I could wave a magic wand, we would have employed Sharon full time. That's a bit of learning. And really, what I would love to pick your brains about in the discussion that's about to follow is, what are your ideas for helping us to balance those voices and really value everyone's experience equally?
Thank you so much, Helen, for a very insightful talk again on the importance of co-production in this area when we are designing interventions. Another important aspect to this piece of work is actually lived experience involvement for the people who are actually from the underserved and underrepresented and marginalized communities. And we have another wonderful speaker here, Damien Juma, who would like to share. We would like to benefit from your perspectives as a lived experience consultant and advisor on how do you think mental health research for underserved and marginalized communities is going on and what needs to be done. Thank you. Over to you, Damien.
Thank you, Osman, and hello to you all from Kenya. It's so lovely to get to connect with you all, and so lovely to get to be on this panel with these amazing people. I mean, I've had like so much intriguing concepts right from the first panel to the second panel. The question that has been posed by Helen, and it's, you know, how do we strike the balance? It's amazing, and I don't have like a direct response or answer that would work for all of us right now. But I have a couple of reflections and questions as well to you all, to the panelists before, and the panelists that we just heard from recently. And one of the things that has been presented is belonging. And belonging is so significant that we are having the finding that we are having from the studies that you are leading. And one question I might be asking is, how then do we make sure that we belong when actually we have so much disparities between us? There is collaboration, but there is no meaningful collaboration and intentional collaboration. There are power imbalances between our collaboration teams. There are also capacity, that is inadequate capacity among ourselves and our teams. How then do we belong if we cannot balance all these issues? How can we belong if you're coming to Kenya, for instance, and you have someone from Kenya who is a postgraduate, and there's someone else from the other countries, the Western countries, they have PhDs and all that, and they have opportunities for fellowships to continue their studies and to build on their skills, while their counterparts from settings like mine do not have the opportunity, or most times are not presented with those opportunities to meaningfully collaborate and belong in the same team that you are trying to create and that you are trying to find a meaningful collaboration with. And two is, how do we belong if really, when you think about someone, for instance, if Damien goes to the UK or Damien goes to the US or somewhere, Damien becomes a migrant. But if Damien was born and raised in the UK and Damien comes to Kenya, then Damien is not a migrant, but they are someone else. I am not sure of the terms to use though. How then do we belong if there still exists this kind of differences and direct barriers? And lastly, from the previous point of view on social determinants of mental health, really, these are significant. And settings like ours, have like incredible barriers to achieving mental health, spanning from investment to access to care, to experts, to supportive environments to thrive and not to survive and all that. And my biggest question really is, then how can we meaningfully and intentionally support the governments with adequate data that comes from our setting, that involves people from our setting, that also makes it a priority to include voices from the setting that this data is coming from, to influence policy, to influence mental health investment, and to also get the data to the people that it needs to get to. Like, how can we make sure that the findings we have from research and all the research we do, which is amazing, does not just rest in journals? How can we make it, accessible to the people that actually need to know about those settings, and in a creative way, in an entertaining way, in a good way to learn? Like, how can we explain those research findings to a class 3 student, pupil here in Kenya, for instance, to understand what that means? If we're going to do like more work in primary schools and like in high schools or like in universities. And then just to finalize, maybe one thing I would also want to or request that I get some sort of expansion on is disparities, really. You have been here for a long time than I have been on Earth, and you've been in the field as well for a long time than I've been. But my question still remains, why do we still remain the most unexplored field of health and medicine in general? Like, why are we not at par with other other sectors of health, and how can we reduce that gap meaningfully?
So actually pretty insightful again, and quite pertinent points that Damien was making, especially around the terminology and concepts and how do we go about it. And while Damien gets back, we can take the discussion forward. And I would like to open this discussion by asking a question. So we have talked about very interesting aspects and some core concepts, as well as bigger constructs around social determinants and the policy. And I'll begin with Meena and Helen and Craig and Shekhar and others around on sharing some thoughts around, are there any success stories of how we can actually do something better or learn from them to promote mental health in marginalized and underrepresented groups across the globe? So any kind of success stories, or what is the best version that you are aware of that we could do? Because there are so many challenges that we've talked about.
Like, I'm happy to start that discussion. So I think, the issue is, isn't it, with a lot of this, there are hundreds of success stories, they don't get shared very well. So often, individual schools are doing some remarkable things, and actually finding a forum and a way for us all to learn from each other is probably the foundation of how we can move things forward in this space. So I don't think that we've got great studies on it. There's an interesting study coming from Belgium looking at different schools and showing that schools that embrace the diversity and seem to value it, those newly arrived children seem to do much better than those schools that enforced assimilation, for example, with rules like you're not allowed to wear a hijab or something like that. So there are indications, I think, that help us understand components that I think are important. I think often in the post-migration environment, what I've seen some environments do well, schools, is I think schools play a key role in bringing families and communities together as well. And the most interesting examples of that I've found is, for example, with celebration of food, which is, just World Food Days where everyone's encouraged, whole families, and that seems to bring about a change. Just like Helen said, you need to feed everyone lunch. It seems that food seems to be the key to most things. And actually, so things like that to enable just a more kind of a way to set the stage for a better sort of integration, I think, is important, because in the kids that I interviewed, not one had been, as they said, to the home of a native English person for a meal yet. So although they might be integrating on certain levels in school, they've got the right classes, they're attending their lessons, the next step of actually true human interaction and belonging did seem to be really lacking time and time and time again.
Great. And you said that there might not be many studies around this. So what do you think is needed more to support that part of work? Because to influence policy, we do need evidence, but if there's no evidence, how do we move forward?
Well, I think it's finding the way to ask those questions. These are complicated questions and much harder to study the impacts of. So we need to develop I suppose we're quite interested in developing kind of more broader level kind of ways of measuring the whole community level of engagement, belonging, and different markers of that. So I think it can be done. It involves bringing the social sciences seriously in to the epidemiological questions we're asking, which is possible but requires a commitment.
And I would add to that by just saying that I think we have to accept that our historical research focus has been very Eurocentric. And it's fascinating hearing what you're saying, Meena, about the importance of community. It's remarkable to me how often in surveys we forget to even ask about support by extended family. So if we can recognise that we have a Eurocentric focus and actually value different perspectives, and I agree, Meena, that's going to take a much more sociological approach, then there are so many obvious things that are obvious to other people. And one of the things I think I've really learned from working with parent collaborators is that, especially if they've been living in poverty, and having experiences that are different from mine, they will see things that are blindingly obvious. And I think, gosh, that should have been blindingly obvious to me, but of course it's not. So if we can actually step down from our pedestals and be much more embracing of other people's experience to shape the questions that we ask, I think we're just going to open a whole new world of research.
That's very important aspect that you have described, just Helen. And I also would like to bring slightly different perspective here, which is still related to this topic, and which is about underrepresented or underserved populations and marginalized, but still in a very low resource settings. So for example, we have evidenced many kind of migrations which are from one under-resourced or underserved setting to another underserved setting. And so what are your thoughts about, like, what are the needs there and how do we move field forward in that context? Because there might not be research capacity, there might be a whole set of lots of other challenges. The policy, like the countries are themselves in a really bad shape. So what are your thoughts about such settings or contexts? Because we are still thinking of migration in a context where someone is coming from a low resource to a high resource setting. What about the rest of the settings?
Such an important point, Isman, and I think for me, you get into some really, really important structural issues in research. Who gets funded? Which journals are ranked? Who gets research fellowships? I mean, there are some fantastic researchers in sub-Saharan Africa, for example, but do they get the funding? Do they get the voice?
Damien, we missed you in the last part. So yes, if you would like to.
Sorry, it's the internet, and when you are being funded to develop digital interventions for like low and income countries, this is Damien, who is privileged but still struggles with the internet. So imagine of the Damien who is out the outskirts of the country, or like places where the internet is still an issue, but still people say we have more internet coverage, we have more digital access and all that stuff, and we need funding to develop interventions that would work in that context using tech, digital stuff. That's a good witness thing. The thing that I was like completing my my statement with, and sorry about that, is that like how then do we intentionally, meaningfully, collaboratively work on these issues that we know are here? Now, we might not necessarily have to start with everyone else, but how do we, the people in this conference, how do we start with us? And then the rest of the people can follow. How do we make sure that we belong? We actually agree or accept to disrupt the things that we feel comfortable around, to disrupt the environments that we are so used to work with, and actually move towards accepting that, hey, Damien has something that I might never know, and Damien needs to be here just as much as Helen, as much as Mina, as much as Usman. How do we make sure that we belong? First of all, people from this conference, and then next time when we meet as a as a panel, or like as a people, then we say this momentum started from here and this is where we are heading. And that way, at least people will come to us and say, you know what, you guys have done it. And so we would like to learn from you and borrow concepts from you on how you've done it.
Great. We have still 3 minutes, and I would like to just maybe as a key takeaways from this panel and from your experiences, we know that there are a number of challenges, but maybe one thing that you think needs to change for us to actually bring a positive contribution in the direction, in the fields of work that you are working in. So what is the key kind of a takeaway that you would like to share? So Damien?
We need to be a little bit more honest with ourselves and accept that there are things we do not know. Just that. Just be a little bit honest with ourselves and accept that there are things we do not know.
Perfect.
And I would stand on the shoulders of that wonderful statement and say, We need to accept that people who do not have school qualifications and who do not have university qualifications may know better than us in many respects.
Shall I add a last comment, Usman? Yeah.
Yep.
Sorry. From my perspective and from my very limited perspective in the post-migration world, I think I would love no school ever to contact me again and say, we've got 5 refugees coming, what should we do for them? And actually start thinking, we've got 5 refugees coming, what should we do for the whole school to ensure that that's a better experience for these 5?
So there are 2 minutes, and I'll take these 2 minutes as a chair because we have a comment, but I'll take the privilege now because my work, a lot of work that I did before coming here was based in Pakistan, and we hosted about 3 million Afghan refugees. And I think everybody knows that Pakistan is a low middle income country, and hosting 3 million Afghan refugees in Pakistan was a big challenge for us, which actually had its own kind of repercussions. And actually, I think that now that I'm in a position that I'm in Wellcome Trust and a funder, and we have a very elaborate culture, equity, diversity, and inclusion policy, SEDI policy. Even as a funder, I think there are so many challenges. So once you're sitting on the other side of the table, you feel like, so once we get to this grant, we are going to make some tangible progress and lead to some solutions. But even if you become a funder, you realize that the things where you need to create or you want to create an impact, there are so many challenges. And as Damien said, like, we need to acknowledge what we don't know. And 2, I think co-creation goes a long way. It's not just for an intervention, I think, but it's also with the community that we work with. And finally, I think we need to work in an environment where everyone is valued and opportunities are all shared. And that's how we as a community is going to actually create a difference. And it's a really uphill task that we are all up against. So thank you so much, everyone, for your wonderful insights and for your amazing presentations. Thank you so much. And back to Helen.
Thank you, everyone, and thank you, Usman, and all of the panelists for a really wonderful session, so insightful. And I was also really appreciated that we could hear from you about how you're co-developing interventions to support mental health of people from marginalised and underserved communities. Really, really great to hear about that and the discussion that emanated from that. So now we're going to move on to our poster session. And this year, MQ has organised a creative way for the posters to be presented to try and make the research they're talking about more accessible. And that's in the format of TikTok videos. So we're now going to watch 4 of these. So I'd really like you just to sit back and enjoy the presentations.
Hi, in this presentation, I will describe how patient and public involvement is used in the process of introducing an evidence-based psychosocial intervention to address perinatal depression in Sri Lanka. Patient and public involvement means actively working in partnership with patients and members of the public to plan, manage, design, and carry out research. Let's start with getting to know what perinatal depression is. Depressive episodes that occur during the period of pregnancy and the first year following childbirth is defined as perinatal depression. The prevalence of perinatal depression is reported to be high in Sri Lanka. Though prevalent, it is a neglected health issue in Sri Lanka. Maternal mental health is not covered in the maternal and child health program of the country. Such integration is far more reachable in Sri Lanka due to the lack of trained mental health care professionals who can provide necessary support and care within communities. Introducing a task-shifted psychosocial intervention to treat perinatal depression in communities is the way forward for Sri Lanka. Task shifting can be done by either transferring the tasks from highly qualified health workers to the health workers with comparatively less training or creating a new workforce with specific training for the particular task. Thinking Healthy program is a task-shifted psychosocial intervention for perinatal depression. It has been proven to be effective in treating perinatal depression in low and middle-income countries such as Pakistan. Thinking Healthy program uses non-specialists such as community health officers to deliver the intervention. Under the Enhanced Sri Lanka project, we are planning to introduce Thinking Healthy program into the primary healthcare system in Sri Lanka. We expect to implement it through public health midwives who are the ground level health workers in Sri Lankan healthcare system. Enhanced Sri Lanka project is carried out in 3 phases. In phase 1, we adapted the Thinking Healthy program to the Sri Lankan context. In phase 2, potential barriers and facilitators for the planned Thinking Healthy program implementation are identified. In the phase 3, an implementation strategy will be developed to facilitate the introduction of Thinking Healthy program to the primary healthcare system in Sri Lanka. A patient and public involvement approach is used in the different stages of the enhanced project. A patient and public involvement group, including stakeholders such as women with and without lived experiences of perinatal depression, was established. The patient and public involvement group worked together with an expert group to adapt the Thinking Healthy program manual. We held several community events to understand the views of the public on Thinking Healthy program implementation in community settings. All the project activities are guided by the community views and patient and public involvement group inputs. Patient and public involvement is essential for a successful introduction of Thinking Healthy program in Sri Lanka.
I'm black, but I don't feel like I am. This was a quote from a young person I interviewed when I was looking into young people's experiences of living in transracial foster placements. This is when ethnic minority youths are placed with ethnic majority foster families. This pilot study was conducted as part of a service evaluation. 6 themes were identified from the interview data. I interviewed 8 ethnic minority young people aged between 12 and 18 living in transracial foster placements. These are the demographics of the participants that we interviewed. 2 of the accounts, YP6 and YP8, had to be discounted due to a significant language barrier. Each individual took part in a semi-structured interview via Zoom. Once the interviews were transcribed, thematic analysis was performed on the data. The results highlight the importance of raising awareness and talking about differences when thinking about how best to support young people living in transracial foster placements. From these findings, there are suggestions that in order for the young people to feel supported, the adults around the child, such as foster carers, teachers, social workers, should initiate conversations about race whilst remaining open and engaged. The findings highlight a need for resources and training to be available to foster carers with advice regarding how to best promote and maintain their child's cultural and ethnic identity. Limitations: a small sample size, which means that it's really difficult to generate these findings to the rest of the population. Another limitation, it was a predominantly female sample size. It would be good to get the male perspective of living in transracial foster placements. Also, this study was only limited to children living in transracial foster placements. What about the children living in residential settings? Maybe there's something different there.
According to the World Mental Health Report, business as usual for mental health simply won't do. Findings from the South Asia GHRU project bear this out. The Pakistani population has an alarmingly high rate of mental health issues which are undiagnosed and untreated. Hi everyone, I am Aruba Aslam and I represent Pakistan, which has the 5th largest population in the world. Pakistan has an alarmingly high rate of mental health issues. I would like to share results of our community-based mental health assessment done as a part of our ongoing GHRU Global Health Research Unit project in Pakistan. This project focuses on community screening for non-communicable diseases in the Punjab, which has the country's largest population. In our study, we reached out to volunteers older than 18 years by conducting screening camps in different rural and urban communities across the province. 34,700 participants were surveyed from more than 200 communities in 10 districts of the Punjab. A lot of effort was invested in maximizing the community and stakeholders' participation. We engaged the local government authorities and health centers in our project. Similarly, local community leaders were involved in organizing the camps. Print material and home-to-home enumeration was used for awareness. Last but not the least, we used a custom mobile health unit to reach out to people. Two standardized questionnaires named as PHQ-9 and GAD were used to quantify the prevalence, that is, presence of anxiety and depression in the community. On analysis, we find out that a staggering 61% of population was suffering from anxiety. Similarly, 68.1% had depression. Both genders were affected equally. Our results indicated that depression was strongly associated with inactivity, being unemployed, less income, and education less than high school. Similarly, health problems like obesity, high cholesterol, and high blood pressure were also strongly associated with these mental health issues. On contrary, exercise, higher income, and education more than high school showed protective tendency. These findings are way higher than those reported by past studies on the same subject, highlighting the gradual worsening of mental health care in our settings. Researchers have consistently reported the high level of stigma associated with mental health illness in Pakistan, with faith healers leading as the first responders and with only 400 trained psychiatrists for entire nation, meaning we have only 0.19 psychiatrists for every 100,000 people. Results are being shared with primary and secondary healthcare department, who is an important stakeholder and local collaborator in the project with us. It is the first ever study conducted at community level that has found an alarming figure of more than 60% of anxiety and depression prevalence in Pakistan. Community-based intervention by involving local stakeholders and community leaders is required to address the situation. We are committed to bring some positive change in the management of mental health in the country. Thank you so much for all your time.
So imagine this. You're on the senior management team at a leading research unit in West Africa with around 1,400 staff. You want to set up a mental health peer support programme, but you're concerned that staff won't engage with it if they think it's being monitored by managers. How do you build trust in the programme, whilst also making sure these peer supporters don't burn out? Well, that's the question that frames the study I'm presenting today, which is a small piece of qualitative research based on my master's dissertation. Based on the findings, I made 2 recommendations for management: co-design the support system with staff and provide opportunities to share information about the programme. Now, we know from the literature that peer supporters have a difficult role. They're navigating multiple identities, and this can come at a personal cost. My research question focused on how peer supporters understood their role and how it aligned with the role description that was given in their training. I carried out individual interviews with people who had been trained as peer supporters, as well as some of the management staff who were involved in making decisions about the programme. I found that the peer supporters I spoke to had a really clear understanding of the role, what it should be, but, well, as in every setting, how they enact this role had been shaped by their context. When speaking about their roles, peer supporters shared the challenges of working and living in a small country where everyone knows everyone. This was perceived as a real barrier to staff engaging with conversations about their mental health, due to fears that it would come back to family or colleagues. The concerns the management staff had raised about confidentiality were real and valid. But there was also a need for greater supervision structures. After speaking really positively about the training, another participant said the only shortcoming was that no one had ever come to ask how they'd been implementing it. To them, that was really important. Otherwise, they said, am I really doing what I'm supposed to? Co-designing a supervision system with staff means that it's more likely to meet everyone's needs, whilst also increasing feasibility and trust. Supervision doesn't mean that sharing names or personal details, but it might mean creating a shared space where peer supporters could help each other or discuss questions they didn't know the answer to. Using existing spaces such as lunchtime seminars is also a great way to communicate to staff about what the programme is and what peer supporters can and cannot do. Since the initial study, I've had several further meetings with the peer supporter team who've discussed things like going to field site meetings and creating posters to spread the word. It's not a quick fix for stigma or suspicion, but it does demonstrate a commitment to making the peer supporter programme more accessible and countering any false narratives. The study was co-designed with Dr. Karen Forrest, who is head of the clinical service department at the unit. A tailored summary of the findings have been written in collaboration with 2 staff who are peer supporters, Alaji M. Jallo and Lamin Lee. Alaji, Karen and Lamin will be leading the implementation of the recommendations at the unit, and Dr. Julia Rosenova, who supervised my dissertation, has continued to provide her support.
Wonderful. I'm going to give them a big clap, as no one else can, because you're all in webinar mode. But I just want to say massive thanks to all our wonderful TikTok presenters for creating such incredibly engaging posters to share their really fantastic research on the mental health of marginalised and underserved communities. I really think that's a fantastic way to share research in a really accessible way. So I'd like to take this opportunity to say an absolutely huge thanks to all of our chairs and panelists today for the really enlightening and thought-provoking discussions. They've raised many, many important issues and challenges in this space today, particularly around the need to consider an intersectional lens when we think about the impact of inequalities on mental health and access to appropriate care. And really in line with our session yesterday, how crucial it is to collaborate with those from marginalised groups and those underserved communities, especially those with lived experience of mental health difficulties when we're designing research and interventions to move this field forward. So they've also highlighted the need to design for the margins, which is a really great phrase from our first session, and invest in research by and services for marginalised and underserved communities. Really being especially conscious of how climate change and increasing income inequalities and political instability are likely to substantially increase those who are considered marginalised. So all of this really underscores the importance of tackling social and economic determinants of mental health. So before I hand over to Lee to tell you about the optional Zoom meeting, I'd like to really encourage people to complete the feedback form about our session today. This will really help us to improve and shape future events at MQ. I'd like to continue to encourage you to share your reflections and takes on the presentations and discussions we've had today on social media, and you can use the hashtag MQ Science Festival to do that. If you've missed the first day of our festival, which was yesterday, you can watch the recording on that and cross-sectoral collaborations on our MQ YouTube channel. And please do keep sharing these with your networks. And I'd also like to encourage you to join our session tomorrow. So we're here all week. Please do come back. Tomorrow we'll be discussing applications of digital technologies in mental health. So I'll now hand over to Lee to tell you about how to join the Zoom meeting to ask further questions and network with other attendees.
Helen, thank you so much for chairing us through a fantastic set of discussions. Thank you to all our speakers and to all of our chairs. A hugely engaging conversation. If you check out the hashtag MQ Science Festival, the conversation has been going on there. And it doesn't finish now. In fact, we want to give space to network, to chat more, to challenge some of the things that we've heard face to face, and get a chance to meet some of the speakers and some of the fantastic TikTok presenters that we've just heard from. So you can do that by, in the chat, you will see that there is a link to join the discussion. So how this will work is you can copy and paste that link into your browser and move across, or when this Zoom shuts down, you'll be dropped back into the lobby ceremoniously, and you can click join the discussion, and that will take you in to the other Zoom room. And in that room, your camera will be enabled, your mic will be enabled, and we'll be able to get together and have a chat about this. We had a really interesting conversation yesterday with a number of the TikTok presenters. Today we'll be in one group, and the conversation will be chaired by our guest tweeter for the day, Mariana Bolivar, who's head of mental health inequalities here at MQ Mental Health. So if you can copy and paste that link into your browser when this ends, the new one will open, or if you drop into the lobby, you can click join the discussion. While you're planning all of that, do remember to fill out the feedback form and send it back to us. We can only make these events even better by listening to all of you. So we'd really love to hear your feedback. Do click the form. And as you are registered for the week, tomorrow we'll be looking at the fact that worldwide people are struggling to access mental health care. In the UK here, 1.2 million people are waiting to see a mental health specialist. In low and middle income countries, 75% of people with a mental health condition receive no treatment whatsoever. How can we apply applications of digital technologies to improve access to mental health care, and what research needs to be carried out to ensure these interventions are effective? And building on our conversation today, the warning ringing in my ears from Shakar that without contextualization of these, actually digital technologies run the risk of widening the inequality gap. So we'll be digging into that in much more detail tomorrow. So copy the link in your browser now. This will be shutting down in about 30 seconds time, while you'll be dropped into the lobby, and you can click join the discussion or copy and paste the link. And we'll see you over the discussion hosted by Mariana Bolivar. Thank you all so much for joining. We'll close this down in about 20 seconds time and see you on the other side.